My name is Debora Woodham, and today I will be presenting my Doctor of Nursing Practice project titled Improving Depression Screening in Older Home Health Patients Using PHQ-2 and the Geriatric Depression Scale. This project focuses on improving the identification of depression in a population that is often overlooked, particularly in home health settings where patients have complex medical needs. Depression is frequently underrecognized in older adults, and this project aims to address that gap through a simple, evidence-based intervention. This project was completed under the guidance of my DMP project committee, including Dr. Jessica Bland, Dr. Lisa Sturr, and Kelly Clements. Their support and feedback were instrumental in helping to guide the development, implementation, and evaluation of this project. Their expertise ensured that this project remained grounded in evidence-based practice and aligned with clinical and organizational needs. Frequently underrecognized, particularly in home health settings, where the primary focus is often on managing chronic physical conditions. Many older adults experience multiple comorbidities, and as a result, mental health concerns may not be prioritized during routine visits. Additionally, depression in older adults does not always present in a typical way. Instead of verbalizing sadness, patients may present with fatigue, withdrawal, or decreased engagement, which can easily be overlooked. At the project site, depression screening was performed using only the PHQ-2, which is a brief screening tool. While it is useful, it may not fully capture depressive symptoms in this population. Untreated depression is associated with poor adherence to treatment, increased morbidity, and higher rates of hospitalization, making early identification critical. The purpose of this project was to improve the identification of depression in older adult home health patients. Depression is often underdiagnosed in this population, and improving screening practices is essential for early intervention. The project question asked whether adding the Geriatric Depression Scale, or GDS, to routine PHQ-2 screening would improve detection of depression compared to using the PHQ-2 alone over an 8-week period. This question was designed to evaluate whether a simple change in screening practice could lead to meaningful improvements in patient care. Shows that depression in older adults is frequently underdiagnosed and undertreated. One contributing factor is that older adults may not openly report symptoms of depression, either due to stigma or because they perceive these symptoms as normal parts of aging. Additionally, depression may present as physical complaints such as fatigue or decreased appetite rather than emotional concerns. The PHQ-2 is commonly used because it is brief and easy to administer. However, its simplicity may limit its ability to detect more subtle or complex presentations of depression. When depression is not identified, it can negatively impact overall health outcomes and increase healthcare utilization. Adults and has been shown to be both valid and reliable in identifying depressive symptoms. Research supports the use of multiple screening tools to improve depression rates, particularly in populations where symptoms may not be clearly expressed. National guidelines also recommend routine depression screening in adults, emphasizing the importance of early identification and intervention. Together, this evidence supports the need for enhanced screening approaches in older adult populations. It was guided by the Iowa model of evidence-based practice. which provides a structured approach for implementing evidence-based changes in clinical practice. The model begins by identifying a clinical problem or trigger, which in this case was under-recognition of depression in older adult home health patients. From there, the model guides the review of current evidence to determine best practices, which supported the use of additional screening tools, such as the Geriatric Depression Scale. The next step involves implementing the change into practice, which was done by adding the GDS as a secondary screening tool alongside the PHQ-2. Finally, the model emphasizes evaluation of outcomes to determine whether the intervention was effective. In this project, that evaluation demonstrated a significant improvement in depression detection. Overall, the Iowa model provided a clear framework for translating evidence into practice and supporting sustainable change within the clinical setting. This project used a quantitative pre-post quality improvement design conducted in a home health setting. The intervention involved adding the Geriatric Depression Scale, or GDS, as a secondary screening tool alongside the PHQ-2. The PHQ-2 was completed during the patient visit, and the GDS was completed after the visit using observed and reported patient data. This design allowed for comparison of depression detection rates before and after implementation. The sample included 176 patients aged 65 years and older who were receiving home health services. All eligible patients were screened using both the PHQ-2 and the Geriatric Depression Scale during the same admission visit, resulting in a 100% screening completion rate. Were used to summarize the screening outcomes, including the percentage of patients identified as positive for depression. A Z-test for proportions was conducted to compare the difference in detection rates between the PHQ-2 and the GDS. This test helps determine whether the difference between two percentages is statistically significant, meaning that the difference is unlikely to have occurred by chance. McNemar's test was also used because this project involved paired data, meaning that the same patients were screened using both tools. This test specifically evaluates whether there is a significant difference in outcomes between two related groups. In this case, it helped determine whether the GDS identified patients differently than the PHQ-2. Together, these statistical tests confirmed that the increase in depression detection with the GDS was statistically significant. This project demonstrated a significant difference in depression detection between two screening tools. As shown in the table, the PHQ-2 identified 6.3% of patients as positive for depression, while the Geriatric Depression Scale identified 64.2%. This is a substantial difference and highlights the limitations of relying on a single brief screening tool in this population. A key finding is that 105 patients who screened negative for the PHQ-2 were identified as positive using the GDS. This suggests that a large number of patients may be experiencing depressive symptoms that are not being captured through standard screening practices. Statistical analysis confirmed that this difference was significant, with a p-value of less than 0.001. From a clinical perspective, this is important because missed depression can directly impact patient outcomes, including adherence to treatment, recovery, and overall quality of life. In practice, this means that without additional screening, many patients will not receive the support or intervention they need. The findings from this project suggest that the Geriatric Depression Scale significantly improves the identification of depression compared to the PHQ-2 alone. While the PHQ-2 is useful as an initial screening tool, it may not capture the complexity of depression in older adults. Many patients may not openly report symptoms and instead present with more subtle signs, such as withdrawal, decreased engagement, or changes in behavior. By incorporating an additional screening tool, clinicians are better able to identify these patients and recognize patterns that may otherwise be missed. This highlights the importance of combining standardized tools with clinical observation to improve accuracy in assessment. In home health specifically, nurses are in a unique position to observe the patients in their environment, which makes this type of screening especially valuable. Several limitations should be considered when interpreting the results of this project. First, this was a single-site project, which may limit generalizability to other settings. The sample size, while adequate for this project, was relatively small. Additionally, the implementation period was limited to 8 weeks, which does not allow for evaluation of long-term outcomes. The Geriatric Depression Scale was not formally integrated into the electronic medical record, which may impact sustainability. Finally, long-term outcomes such as referrals, treatment initiation, and patient improvement were not tracked. Despite these limitations, the findings still demonstrate a meaningful improvement in depression detection within this population. The findings from this project demonstrate that adding the Geriatric Depression Scale to routine screening significantly improves the identification of depression in older adult home health patients. These results suggest that relying on a single screening tool may not be sufficient, particularly in populations where symptoms are not always clearly expressed. Importantly, this intervention did not increase workload, as the GDS was completed after the patient visit, making it a practical addition to the clinical workflow. This is critical in home health, where time constraints are a major factor in clinical decision making. This project also addresses a gap in current screening practices by providing a more comprehensive approach to identifying depression. From a broader perspective, this supports the need for system-level changes that improve how we assess and respond to mental health concerns in older adults. This approach allows clinicians to move beyond surface-level screening and identify patients who may otherwise fall through the cracks. Of this project for clinical practice are significant. Improving depression screening allows for earlier identification of patients who may be at risk, which can directly impact patient safety and outcomes. Early identification also supports better treatment adherence, as patients are more likely to engage in care when their mental health needs are addressed. This may also contribute to a reduction in hospitalizations, particularly in older adult populations with complex conditions. Additionally, this project supports interdisciplinary collaboration, as addressing depression often requires coordination between multiple healthcare providers. It also reinforces the importance of using evidence-based tools to guide clinical decision-making. This reinforces the clinical role of nurses in recognizing both physical and mental health needs in vulnerable populations. From a clinical perspective, this project has direct application to everyday practice in home health settings. Nurses are often the first point of contact and are in a unique position to observe patients in their home environment. This allows for a more comprehensive assessment that includes both physical and mental health needs. By improving depression screening, clinicians can identify patients earlier and initiate appropriate interventions, which can improve engagement and adherence to treatment plans. This is particularly important in older adult populations where depression may not be openly reported and may instead present as changes in behavior or function. For example, a patient may appear withdrawn, less communicative, or less engaged in their care, and without additional screening, these signs may be attributed to aging rather than depression. By incorporating tools like the GDS, clinicians are better equipped to identify these subtle changes and respond appropriately. This project supports a more holistic approach to patient care by addressing both physical and mental health needs. Ultimately, integrating enhanced screening practices into routine care can improve outcomes, reduce complications, and improve overall quality of life for patients. The results of this project demonstrate that adding the Geriatric Depression Scale to routine screening improves the identification of depression in older adult home health patients. The findings highlight that the PHQ-2 alone may not be sufficient to detect depressive symptoms in this population, particularly in patients who may not openly report symptoms or who present with more subtle nonverbal indicators. Importantly, this intervention was simple to implement and did not increase workflow and was able to fit within existing clinical workflow, making it both practical and sustainable in real-world practice. From a clinical perspective, improving depression screening allows for earlier identification of patients who may benefit from further evaluation and intervention, which can positively impact treatment adherence, recovery, and overall quality of life. From a systems perspective, this project demonstrates how a small targeted change in practice can improve a process that affects multiple patients and supports more consistent evidence-based care. In addition, this project highlights the importance of recognizing depression as a critical component of overall health rather than treating it as a secondary concern, especially in older adult populations. As healthcare continues to move towards a more patient-centered and holistic model of care, integrating mental health screening into routine practice will become increasingly important. If this work were to continue, future efforts would focus on long-term outcomes, including referral rates, treatment initiation, and patient improvement, as well as potential integration into the electronic medical record to support sustainability. This experience has strengthened my ability to apply evidence-based practice, evaluate clinical processes, and implement meaningful change in patient care as an advanced practice nurse. In addition to improving detection rates, this project also highlights the importance of incorporating mental health assessment into routine care rather than treating it as a separate or secondary concern. In home health, patients are often managing multiple chronic conditions, and mental health can easily be overlooked. However, untreated depression can directly impact a patient's ability to engage in care, follow treatment plans, and maintain overall health. By improving screening practices, clinicians are better equipped to recognize these needs early and respond appropriately, which supports safer, more effective, and more comprehensive patient care. Ultimately, this project supports a more comprehensive approach to care by ensuring that both physical and mental health needs are identified and addressed. of evidence-based screening practices. I want to thank you for listening to my project and thank everyone who has supported me over these last few semesters. It has been a difficult road, but I appreciate everyone's patience. Thank you very much.